bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuromonitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Velo people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Hello and good morning to all our doctors and participants. Apologize for the minor delay and welcome you all to today's webinar on pain management presented by the Naruvi Hospitals under the Hindu Wellness Series. Pain is inevitable and suffering is optional, is what we are going to discuss today. And first, I would like to invite Dr. J. Jayasudha. She's the consultant in pain physician at Naruvi Hospital, Vellore, to give her presentation on art and science of pain medicine. After completing her MBBS from PSG Institute of Medical Sciences and Research, Coimbatore, Dr. Jayasudha did MD in anesthesiology from Christian Medical College, Vellore. A gold medalist from Dr. MGR Medical University, she has 15 years of experience in anesthesiology with special interest in ultrasound-guided local anesthesia. She has also pursued a fellowship in advanced pain management and has been practicing pain physician for the past 5 years, exclusively dealing with patients having chronic musculoskeletal pain, neuropathic, and cancer pain. Dr. Jayasudha's areas of interest also include regenerative medicine in degenerative musculoskeletal disorders and sports injuries, radiofrequency ablation for chronic joint pain, and neuropathic pain and palliative care for chronic illness. So let us all hear it from Dr. Jayasudha. Welcome, Doctor.
Thank you, ma'am, for the wonderful introduction. I hope you're all able to see my screen.
Yes, we can.
Good morning, everybody, and I welcome all the participants who have gathered here to attend this webinar on pain management. This is more to create an awareness about the specialty among the general public. So I am Dr. J. Jayasudha, consultant pain physician at Naruvi Hospitals. I'll be talking about the art and science of pain medicine for the next few minutes. So what is this pain medicine all about? Okay. So pain, may I request all the participants to mute themselves, please? So what is this pain medicine all about? So pain is the most common reason for which most of the patients seek a healthcare provider. And most often it is either undertreated or underdiagnosed, or sometimes patients fail to approach the right kind of doctor for getting their pain treated and often ignore the symptom, which leads to a lot of disabilities and economic burden later in their life. So the learning objectives that we will be having in our session would be briefly define about what is pain, the types of pain that are commonly found, the chronic pain disease burden in India, the role of the pain physician, and some of the minimally invasive interventions that we do to relieve pain, and most importantly, the role of interdisciplinary management in managing chronic pain. So the IASP, which is an international association for the study of pain, have recently revised the definition of pain in 2020. Pain is an unpleasant sensory and an emotional experience associated with or resembling that associated with actual or potential tissue damage. So what is this? So pain is something unpleasant. It's not going to be pleasant for everybody. And it is also associated with an emotional experience. Obviously, somebody in pain is going to be dull, depressed, crying, lack of sleep, and all that. And there can be a actual tissue damage, or there may not be a tissue damage, and still the patients can perceive pain. So that is something important. So put it in a nutshell, Robert Wycross said, whatever patient says it hurts is pain. So there are few descriptors to this pain. Pain is always subjective. That makes the treatment also difficult. As in the case, if somebody has a blood pressure, you check the blood pressure and say it is high. How do you say whether patient is having, severe pain, moderate pain? How do you believe them? So it's very subjective, and it varies from patient to patient as well. It's perceived differently by each person. And pain is not just the physical pain. It's not just the headache. It's not just the backache, but it is also associated with emotional pain in the form of depression and anxiety, social pain in the form of interference with work, reduced income, and other things, and spiritual pain as you challenge your belief. As in cancer patients, they have their beliefs. Why did this happen to me? Why not to others? So treating the pain in total pain, treating all these components becomes very important. So, what are the types of pains that we usually encounter? So, pain is broadly classified into acute pain and chronic pain. Acute pain is more or less as it's a symptom of something that's happening wrong in the body. If you have a surgery or a trauma, you have pain, so that is protective. And whereas chronic pain, it's a disease by itself. So how do you? So there is a time duration that is given, as ma'am asked rightly in the beginning. So any pain that has not subsided within 3 months duration will come under acute pain, and any pain that is going beyond 3 months will become chronic pain. And our aim is to prevent chronic pain. So treating acute pain effectively would in effect prevent chronic pain. And chronic pain is again divided into three broad categories: nociceptive pain, nerve pain, and mixed pain. Nociceptive, basically coming from the muscles, skin, skeletal tissues, bones. Nerve pain coming from the nerve, obviously, and there will be some mixed component where it's coming from both. So, what is the disease burden in India? So, chronic pain affects more than 30% of the people worldwide, and experts say that what we are seeing is just the tip of the iceberg. So, many go unnoticed, many go, they don't even reach the healthcare provider. So, the strange thing is the prevalence is very high in females for some reason, 25% in females, especially in the prime age group, and prevalence steeply increases beyond the age of 60. And as we all know, we are having a aging population. There's increasing number of aging population due to the increase in the lifespan, leading to a lot of degenerative diseases, which leads to chronic pain. So what are some of the causes that leads to chronic pain? So one, as I said, was increase in the lifespan, elderly population leading to knee pain, shoulder pain, back pain. They develop fractures, which leads to chronic pain as well. Increase in the sedentary lifestyle, increase in the manforce in the IT field. So they work for prolonged hours, 8 hours, 10 hours, improper posturing during that time. Increased use of smartphones, lack of regular physical activity, which has led to increase in obesity and diabetes, increased incidence of malignancies, increase in sport activities. Many people now go for marathon running, walking, various other sport activity, which causes sport related injuries and which leads to chronic pain. Increase in the stress levels of depression, which also has a bidirectional association with having chronic pain. And increased use of two-wheelers to travel to their workplace. So what is this pain cycle? So why, if we do not treat this pain appropriately in the beginning, affects the whole personality by itself? So persistent pain leads to the person being less active, loss of fitness and weak muscles and joint tissues. They lose energy, feel tired all the time. They have negative thoughts and fears about pain. They have depression and mood swings, and they frequently take off from their work, and which leads to a financial burden on the family, affects their relationship, and this leads to a vicious cycle. So, what is awareness about this specialty? How many of the people or the public or even the doctors know that such standalone pain clinics are available, and one can approach the pain physician for treating their pain in a holistic manner. So most in this study, if you see, it's done in AIMS by Dr. Sushma Bhatnagar, where you see that most of the patients visit a general physician or sometimes even take alternative medicine therapy like homeopathy or Ayurvedic medicine for sheer pain of fear of taking painkillers. So just about 4.8% go to pain physicians actually. So what is this pain management? So this specialty is a new specialty, been there for in the Western country for more than 10 decades. It's been in India for the last 10 years, more in the metros, and now coming up in the other hospitals, tier 2 cities as well. Basically, we deal with trying to understand the pathophysiology of pain in each of the pain disorders, newer concepts of analgesics therapy, newer drugs to manage pain effectively with less side effects, use of interventions in the pain management to diagnose and treat pain, and interdisciplinary management of pain. So, what do we do as a pain physician in the pain clinic? So, as a regular doctor, we also take a detailed history of where is the pain, how long is the pain, what is the nature of pain, is it aggravated by certain thing, is it relieved by certain thing, and we take a detailed family history, personal history, all those. Apart from that, we try to rule out the red flags. What are the red flags? Red flags are if the patient is having some tumor or a fracture or an infection, we would like to refer these patients to appropriate consultants early. And if there are any yellow flags, as you know, patient is having background psychological overlay like depression, anxiety, which also increases the pain behavior. So we try to do a co-management with the psychiatry and the psychology counselors to improve the treatment of the pain for the patient. So we do physical examination, a thorough physical examination, order for specific tests that are needed to find out the cause of the pain. And more importantly, nowadays, pain physicians are well versed in doing musculoskeletal ultrasound. The ultrasound is set up in their own pain clinic where they can use to scan to see what the problem is, and even use the ultrasound for both diagnosis and therapeutic injection. So it's something like a stethoscope for a pain physician nowadays. So, what are all the criteria for which you refer a patient to the pain clinic? So, any pain that has not responded for conservative therapy for more than 2 weeks, they can be referred to a pain clinic. Post-op persistent pain, that is, you've had a surgery and for more than a month the pain is going on, you can visit the pain clinic. Joint pain, back pain, muscle pain, chronic headaches and orofacial pain. Patients who cannot undergo a proposed surgery due to their comorbidities can be referred to pain clinics. Cancer pain, chronic nerve pain, and sports injuries can be referred to the pain clinics. So, in the pain clinic, as I said, other doctors will see the blood pressure and all that. We, in addition to that, assess the nature of the pain. How do you assess? So, we have certain tools to assess whether the pain is mild, moderate, severe, because the treatment varies according to this assessment. So, we see if the pain score at rest is 3, and when I do an activity, it becomes 6, that is severe. So, what is the pain score after I have initiated some treatment? What is the pain score during follow up? We encourage them to maintain a pain diary. So, when the first visit it was 10, and I've done something and it has become 5, and after 1 month it has become 2, and they are able to get back to their activity. That sort of follow up is very important. Most of the pain is treated by non pharmacological methods, conservative management, by just lifestyle modification, posture correction, educating the patient, reassuring and allaying their anxiety, weight reduction. Obesity is the most important cause these days. Weight reduction, physical and rehab therapy, and psychological support in the form of cognitive behavior therapy and biofeedback goes a long way. Next only comes the pharmacological therapy, and even in the pharmacological therapy, we use a step ladder approach. As I said, if the pain is mild, we treat with very mild analgesics like paracetamol in step 1. We add on analgesics as and when required as the pain becomes better, and if it is too bad, we do some minimally intervention procedures which are image guided in step 4. So I'm very proud to say that in Naruvi hospitals, we follow the interdisciplinary pain management where we work along with the orthopedicians, spine surgeons, anesthesiologists, pain physician, psychiatrists, rehab specialists, and do the best for our patients. So a small word about interventional pain management. It is basically we do some small interventions to permanently or long term give a pain relief by means of injections therapy and image guided therapy. It basically fills the gap between the pharmacological management and the more invasive operative procedures. So how do we do it? We use X-ray machines and ultrasound machines to place our needles exactly in the target where we need to ablate the nerve or inject the drug, so that the abnormal pain-carrying signals are blocked. We do this radio frequency ablation for knee pain, back pain, and shoulder pain, which relieves the pain and also helps the patient take less of oral medications to relieve the pain. And we do use regenerative therapy. Like patient's own blood is taken and centrifuged, platelets are separated, and we inject them into these tendons and ligaments which are damaged into the joints in degenerative conditions for to promote healing. So it's one's own blood that is used, and there's no side effects as well. And in nutshell, we need to understand that total pain, that is the biological, social, and the psychological aspects have to be dealt together. So multimodal approach with medical management, interventions, psychological therapy, and physical therapy should go hand in hand. So in the end, chronic pain is a very complex disease and not a symptom. So you need to have a focused treatment on the mechanisms, and biopsychosocial and interdisciplinary approach is very important. Thank you so much for giving me an opportunity. And the take-home message is kindly do not ignore any pain and seek the help of the pain specialist for interdisciplinary management. Thank you, ma'am.
Thank you, Dr. Jayasudha. That was a really exhaustive and a very, very revealing presentation filled with facts and statistics. And I'm sure our audience will have a lot of questions based on that. I'll now invite our next panelist, who is a pain and interventional spine physician, Dr. Karthik Natarajan. He's also the director of Synapse Back and Spine Clinic at Apollo Hospitals, Chennai. He's a gold medalist in MBBS from Sri Ramachandra Medical College, and it is MD from Kasturba Medical College, Manipal Academy of Higher Education. Besides his DNB from the National Board of India and FIPM from Germany. Dr. Karthik has held multiple positions during his career that include as chairman of World Institute of Pain India chapter and secretary of Indian Society for Study of Pain in Tamil Nadu. He was also awarded the Pain Physician of the Year of India in 2017. His expertise is in performing basic and advanced pain and spine interventional procedures for musculoskeletal, sports injuries, and chronic pain conditions. So I invite him now to give his presentation on the common causes of back pain and management. Welcome, Dr. Karthik.
Thank you very much. Thank you very much for the kind introduction. I hope I'm audible and my screen is visible.
Yes, sir.
Right. So at the outset, thank you to the Hindu Wellness Program and the Naruvi Hospital for including me in the schedule. So I'm very happy to be part of this program. Right. So we are talking about conditions which are essentially involving the pain clinic, and we are talking about back pain and so many conditions, right? So when we are talking about various conditions, the commonest thing that we see in pain clinic is back pain. So I've been practicing pain. So I'm a specialist in musculoskeletal pain conditions. I also run a spine clinic in Adyar in Chennai. So my core area is taking care of patients with back and neck pain, besides taking care of joint and nerve related pain. Now, one of the common things that we see among these patients is back pain, right? So when we talk about back pain, we see most of these patients have non-specific back pain. So because the pain is posture related, this pain is work related, this is because they don't maintain good ergonomics during their work position. So this is something that we do see. Now, when you see these patients and you are going to assess these patients, one of the common things as a doctor that you're worried about is how to enhance his back pain and how to take care of his spine. So essentially, I'm going to be talking mainly about how to avoid back pain. Now, I'm going to talk to you about 10 points here. So I have 10 minutes. I'm going to talk to you about 10 points to avoid back pain and to have a healthy spine. So that's my focus today, right? So we do see patients with back pain. We investigate them. We do their x-rays. We do their MRIs. We also do a lot of hi-fi treatments. We do injections in the back. We give physiotherapy. We do surgeries and stuff. What is the most basic stuff that you want to do when you're treating patients with back pain, right? So I'm going to talk about how lifestyle can help your back, right? Point number one, how do you want to lift your weight, right? So we do find that patients have some jobs in which they are lifting something heavy. So one of the things that I like to tell my patients about how they lift weight is very important is you don't want to be bending your back here. You want to be keeping your back straight. Bend your knees, go to a squat position and lift up the weight. So this is very important, especially if you're in a job which includes lifting something heavy. So if you're lifting something heavy and you have a back-related problem, what would be a good idea is keep your spine straight. Instead, bend your knees, go to a squat position, get the weight as close to your body as possible, and then lift it. This is the first lifestyle change. Next is, we see a lot of patients who routinely use two-wheelers and three-wheelers. These patients use two-wheelers like bikes and scooters to go to their work. Now, what happens is somebody with a back pain who's using a very jerky road and you're having a very jerky ride, the road is bumpy, and each time you go, you're going to hurt your back. So in general, the advice from the doctors for somebody with a back pain is it is better to use a four-wheeler than a two-wheeler or a three-wheeler. And you have to be very careful if you're using a long distance and the road is very bumpy, a lot of speed breakers are there, ditches are there. So that is going to hurt your spine. So a four-wheeler, which could be a bus or a car or a train, is better than a two-wheeler or a three-wheeler for somebody with a back. Next. This is the ergonomic work position. So a lot of us initially were working at home during the pandemic. Now people have gone back to their offices. Now, wherever you're working, what we encourage patients to do is we don't want you to be sitting with your back in a bent position. So we want you to sit back. We want the lower back to be touching the back support in whichever chair you're using. Take the chair closer to the table. The monitor needs to be there at the correct height, at the correct level. An armrest is a good idea. And if you're going to be sitting for long hours, you're going to take periodic breaks. So every 45 minutes to 1 hour, you get up, stretch yourself, get some water or something like that. So the position of the back when you sit in the chair is really important. We want you to sit back in the chair. The lower back needs to be touching the back support. Next. For patients with neck pain, we want you to keep your head neutral when you are reading, when you are watching TV, when you're looking at your mobile. The more you bend your neck, the more likely you're going to put pressure on the cervical spine. So in principle, we want you to keep your head in a neutral position. If you're looking down too much and then bending your neck and then looking at devices, you're going to hurt your neck more. So keeping your head in neutral position is encouraged. Don't bend your neck too much if you want to avoid neck pain. Next, what is the ideal bed mattress that you want to use if you're having back? So you want to use a comfortable bed mattress. At the same time, you don't want it to be too soft. A mattress which is too soft, and if you're sinking into the mattress, is not ideal for you. A mattress which is too hard and which is not giving way at all is also not ideal. So you want a firm bed mattress, and that would be the best way to go about it with a medium-sized pillow. Sometimes with patients with back pain conditions like disc prolapse or disc herniations, we encourage them two positions to reduce the tension in the leg. So we encourage patients sometimes to lie down with the pillow under the knee if you are lying down straight, and if you are lying down sideways, to keep a pillow between the knees. So you'll notice that if you lie down in this position, the tension in your back is minimal. So patients with back pain will benefit if you keep a pillow below the knee, or if you keep a pillow between the knees if you're lying down side. What is the correct pillow for somebody who's lying down? So your pillow shouldn't be too high. So we don't want you keeping 2-3 pillows. At the same time, no pillow is also not ideal. So somebody with a neck pain, what is recommended is a medium size pillow. So your ideal pillow is somewhere around 3 to 4 inches high. At the same time, we don't want people to lie down and watch TV, read, or text. You can do all of this in sitting position. And once you are done, go to sleep in a medium size pillow. So medium size pillow is recommended. So your ideal pillow is somewhere around 3 to 4 inches high. So basically, I'm talking to you about various steps that you will do to avoid back and neck pain, and you will talk and to keep your spine healthy. The other things that you want to be careful about are, we need you to be adequately hydrated. So we encourage patients to drink at least 8 large glasses of water. So we are looking at somewhere around 2,500 ml of water every day, unless you have a kidney condition and you cannot take too much water. And 8 glasses is mandatory. So that means besides drinking water after your meals, you should be drinking extra glasses of water as well. People who are smoking need to stop smoking because smoking compromises blood circulation to the spine. What is this ideal body weight? So the ideal body weight is your height in centimeter minus 100. So if you see an average Indian male or female patient, the men should have a weight somewhere around 70 kilos, and the women should have a weight somewhere around 60 kilos. So this is an ideal weight for an average Indian population. Anybody who are on the heavier side should work on reducing the weight, which puts more strain on the back. Next lifestyle change is floor activity. So if you are one of those people who are doing floor activities like sweeping and mopping, you want to be using a long handle for sweeping and mopping, so you can stand straight and do these activities. So we don't want you to bend your back and do these activities to take care of your spine. The last lifestyle change I'm going to talk about is regular activity. So we encourage patients to walk regularly. Half an hour of walk would be a good idea. Getting good sunlight would be a good idea. So I wanted to keep it simple. So I've advised 10 lifestyle changes to take care of your spine to have a healthy back. Remember, unlike joints, we are able to replace the joints if the joint is worn out. We won't be able to replace the spine. So still now we have not found spine replacement. So you have only one spine. So take good care of your spine. Thank you very much. And I will be happy to answer your questions on pain management or back pain. Thank you.
Thank you, Dr. Karthik, for that very elaborate and valuable inputs. Our third and final finalist for today's session is Dr. Shainika Rajagopal, who's the team leader for the Department of Psychiatry and Child Development Unit at Naruvi Hospitals, Vellore. She completed her MBBS from Salem and MD Psychiatry from the Institute of Psychiatry at Madurai Medical College. And she also has a fellowship in Child and Adolescent Psychiatry from Christian Medical College, Vellore. Currently, Dr. Shainika's areas of interest include early intervention for autism, neuropsychiatry, and mental health. Her presentation is going to be on chronic pain and psychiatric morbidity. A very warm welcome to you, Dr. Shainika.
Thank you, ma'am, for the kind introduction. I'm sharing my screen. Is my screen visible?
Yes, it is.
Warm welcome to all of you, and thank you for joining us on this Sunday morning. An interesting topic for discussion: chronic pain and psychiatric morbidity. I'm very sure so many people in the forum would be wondering what is the role of a psychiatrist here in the pain forum. So I have much more to discuss here today. So coming to the outline, first I'll be talking about what is chronic pain, 2 case vignettes, clinical features of depression, link between chronic pain and depression, neurobiology and treatment options available. Coming to chronic pain, as Dr. Jayasudha mentioned, any pain which is persisting for more than 3 months is chronic pain. We are worried about chronic pain because chronic pain is the major public health problem and the leading cause of disability in the world. It interferes with daily functioning and is often accompanied by intense distress. Studies show that chronic pain often leads to depression, and 85% of the patients with chronic pain have comorbid severe depression. So, coming to the next part of my presentation, where I'll be talking about pain symptom as an indicator of depression. So, how does the client come to psychiatric clinic? This is the most common scenario which we see in our daily psychiatric clinics. Client comes to me saying, I don't know why my doctor referred to you. I have abdominal pain for past 6 months. All investigations done and all were normal. Endoscopy was also done. It was also normal. My doctor said that the pain was related to stress. And when I asked him, what do you think about it? The client says, I'm completely normal. I don't have stress. And this cannot be because of stress. And I have to find out what more tests needs to be done. I have to find out another doctor. So this is how patients come to psychiatric clinic. They have done investigations for the pain. All the investigations are normal. And then they come to us for psychological evaluations. So what the history we ask from the patient, we then go on to ask about the emotional state of the patient. How was the patient over the past 6 months? The patient says that I'm sad, I'm depressed, I'm dull, I'm anxious. I'm having a lot of negative thoughts, distressful thoughts, helpless, hopeless thoughts, suicidal thoughts. And my sleep is disturbed, my appetite is low. And all these are pointers towards depression. So when do we diagnose depression? What are the clinical features of depression? So the first important clinical feature of depression is depressed mood. Feelings of sadness, feelings of pervasive sadness. I'm sad all the time. I'm low all the time. I'm feeling helpless. I have helpless, hopeless thoughts all the time. So these depressed mood, when this depressed mood is associated with reduced or excessive sleep. Sleep can either be reduced or it can be excessive. Appetite can be reduced, which causes weight loss, or it can be excessive, leading on to excessive food intake, or it could be even weight gain. So weight loss or weight gain, together with fatigability. Patient says that I'm always tired. I don't know why I'm tired. I'm always too tired, too depressed and sad, and I don't have interest to do my past pleasurable activities. Previously, I was interested in swimming, dance, music. I don't have interest in any of those. Along with this, patient can present to us with multiple painful bodily symptoms. It can range from head to toe. The pain symptom can range from head to toe. When the patient comes to us with feelings of depressed mood is accompanied by sleep and appetite disturbance, and these symptoms are going to impair the patient's functioning. The patient is not able to function as before, not able to function well, going to cause impairment in their functioning, going to cause dysfunction in their living. Then we diagnose a depressive disorder in a patient. The minimum duration of symptoms is patient should at least have these symptoms for 2 weeks, and these symptoms should be impairing the patient's functioning. Then we diagnose depression. So what are the physical symptoms with which these patients can come to us? As I mentioned, these patients can come to us. The pain symptom could range anywhere in the body. It could be from head to toe. They can have headache, back pain, chest pain, neck pain, soreness of more than half the body muscles, dizziness, tightness in the chest, muscle tension, shortness of breath, palpitation. So all these symptoms could be part and parcel of depression per se. So we now understand that depression itself can present with lot of pain symptoms for which these pain symptoms, doctors have evaluated the cause for pain. They have gone to gastro for abdominal pain, but the doctor says that there is no cause for pain in the abdomen. They have gone to neurologist for headache. The doctor says that there is no true cause for headache, but still all these pain symptoms could be part and parcel of depression. Depressive disorder itself can present with a lot of painful somatic symptoms. Coming to the second part of my presentation, the first part we dealt with depression presenting as pain symptom. The second part is patients with chronic pain presenting with depression. So here is the second case vignette. A 55-year-old female coming to a psychiatric clinic saying, I have knee pain for 2 years. My doctor said that I have osteoarthritis knee, which is because of the degenerative changes in my knee. I'm taking multiple painkillers for my knee pain. I'm depressed. I'm not able to do any household chores as before. I'm sad. I'm worried. So this patient has now an identifiable cause for pain. The knee pain, the cause for knee pain is osteoarthritis knee, but along with this knee pain, the patient is also having depressive symptoms. Why is that patients with chronic pain, the pain which is going to persist for more than 3 months is chronic pain? So why is that chronic pain patients are having depressive symptoms? How do we understand the link between chronic pain and depression? So as Dr. Jayasudha rightly mentioned in her presentation, there are a lot of things for a patient to worry about in patients with chronic pain. They worry about their employment because they're not able to function well as before. They're not able to walk as before. They're not able to go out, do some chores as before. They're worried about their general health. They're worried about their finances. They're worried about the medications. They're worried about the need to take medications. They're worried about the money spent on the medications and doctor visits, hospital visits, lack of employment. So we do understand there are a lot of causes why patients with chronic pain need to worry about. And because of this constant worries go on in their mind, and this vicious cycle is going to continue. As Dr. Jayasudha rightly mentioned, there is a psychological vicious cycle, which is also going to happen in these patients with chronic pain. Patients with chronic pain always feel angry. Why me? Anxiety. Oh, what if I go there and my pain will come again? Fear, distress, I'm intensely distressed because of the pain. All these psychological symptoms again going to cause impoverished mood, negative emotional state. When you're in a negative emotional state, again your pain perception will be high. I'm going to perceive increased pain and my pain is going to increase. So this psychological vicious cycle is going to continue. And I'm also going to tell you about the physical vicious cycle. So I'm not able to walk because of pain. So I restrict my movement. I don't go out. I remain in room. And when I continue to remain in room, a lot of progressive deconditioning is going to happen. With the decreasing activity, pain is going to worsen, more activity avoidance. And this cycle of avoidance and continuation of pain is going to continue forever. Is it only? So now I'm saying chronic pain, the patients with chronic pain have a lot of things to worry. And so the pain cycle is going on. Is this only this? No, there's something much more beyond this, beyond the psychological aspects. This area is the most important area. Why a psychiatrist or what the psychiatrist is interested in. So I will now go on to explain the neurobiological link between pain and depression. So what is neurobiology? I've put it, it's all in our brain. So the pain perception or depression, it's all in our brain. I'm going to, next 2 or 3 slides are quite interesting. It's for people to understand how pain perception is happening and how the perception of depressive symptoms and feelings of depression is happening. So this is the circuit which is operating in our brain. Similar to the electric circuits which are there outside, we have certain circuits which are operating in our brain. This circuit is the circuit which is responsible for depression. Dysfunction of this circuit. So we have outer part of the brain and inner part of the brain. The outer part of the brain, which is we call cortical and subcortical areas, dorsolateral prefrontal cortex, ventrolateral prefrontal cortex, together with anterior cingulate, orbitofrontal cortex, or the cortical areas which are involved in the emotional processing. There are connections between these outer and inner parts of the brain, which is going to regulate our emotions, and any dysfunction in this circuit is the main reason for feelings of depression and sadness. So I'm going to now talk about the link between this circuit, which is operating for depression, and the discerning pain pathways. There are other areas of discerning pain pathways. The main discerning pain pathways via these two areas, the green areas. As I mentioned, all these yellow areas are dealing with our emotional processing or processing our emotions. You can see there's a link between these yellow areas and the green areas of periaqueductal gray and rostroventral medulla. You can see the link between these pathways. So these areas of the brain are also connected to discerning pain pathways. All these blue areas are pain pathways, which is going to carry our pain signals to the body parts. So the circuit of depression or circuit of pain. So the same circuit which regulates our emotion is sending signals to the pain pathway. Still more explaining in detail. So I'll go from the body parts. This is the pain can originate from any body part. See, this is, they have given it as a forearm. Pain is originating from here. And I'm going to tell you how pain is going to get processed in our brain. So this is the cross-sectional image of the brain. And you can see this image. I'm going to tell you how pain is going to reach our brain. So I'm perceiving pain in my forearm. From the forearm, there is a peripheral nociceptive receptors, as Dr. Jayasudha mentioned. From this nociceptive receptors, it's going to travel via dorsal root ganglion. And from that, through medulla, midbrain, thalamus, it's going to reach our brain. So ultimately, wherever the pain may be in the body, it could be from the head, it could be from the abdomen, it could be from the hand, it could be from the legs. Pain anywhere in the body is finally the signals are reaching our brain. So what is happening in our brain? We have a lot of areas in the brain which is going to process our pain. So this sensory discriminatory area is the main function of this area of the brain is to tell us where is the pain, what type of pain is that. And these areas, which is insular cortex, anterior cingulate, motor cortex, all these areas is going to tell us how severe is the pain, how much severity am I going to perceive, and am I going to perceive it unpleasant? Am I going to, how am I going to perceive the pain? All this modulation, pain perception, all these areas are important in understanding the pain perception and modulation. So once the pain, after this pain is getting processed in these areas, they are again going to travel down via rostroventral medulla. From medulla, it is again going to reach the dorsal root ganglion, again it is going to reach your arm. So wherever the pain may be, the pain is going to travel all the way to the brain. In the brain, the pain is going to get processed, and then from there, it is going to reach our arm. What is the significance behind depression and chronic pain? You may be now surprised to see that the same areas which I mentioned in the depression circuit, insula, anterior cingulate cortex, prefrontal cortex, is the same areas which is again going to process your emotions. So the same circuit now is implicated for pain, and the same circuit is implicated for your depression as well. So apart from the circuits, which is common for both chronic pain and depression, we also have other mechanisms by which can explain the depressive pain syndrome. We have other mechanisms of our stress hormones release, inflammatory mediators. A lot of these together happen with the circuitry changes, and also there are chemical changes in the brain, neurotransmitters changes in the brain, which will explain the this depressive pain syndrome. So we now understand there is a very complex bidirectional relationship between chronic pain and depression. We don't know which comes first, either whether depression comes first or the pain comes first. Chronic pain can lead on to depression, and depression can also present with symptoms of chronic pain. So it is not only psychological, there are also evidence from the circuitry changes in the brain. The same circuit which operates for pain also operates for depression. So here comes the treatment options. So if I'm saying both are same, so what are the treatment options available? So patients with chronic pain who have comorbid depression, we have some molecules which are medications, antidepressants, which is going to help, which is going to be of help both for depression and pain. So we have molecules, medications like SSRI, which we call as antidepressants. Usually antidepressants acts on two chemicals, which is serotonin and norepinephrine. These two chemical changes is mainly related to depression. So when we treat the patients with antidepressants, the patient not only gets better, not only the patient's mood gets better, but also the patients will have reductions in pain perception. So coming to, apart from medications, what else we have? As Dr. Jaiswar rightly mentioned, we do a lot of psychological therapies. Evidence-based therapy is available for cognitive behavior therapy, where we will address the negative cognitive distortions present in the patients with chronic pain. And we have a lot of mindfulness-based therapy, biofeedback, yoga, exercises. All these options are available for patients with chronic pain who have comorbid depression. So to conclude, chronic pain and depression are often comorbid conditions with common neurobiological underpinnings. It's not mere psychological. Psychiatrists are an integral part of multidisciplinary care team of chronic pain management. Management of depression aims to improve the quality of life and functioning of those patients with chronic pain, thus reducing the disease burden. Thank you for this wonderful opportunity. Thanks to Naruvi and the Hindu Wellness Series, and especially Dr. Jayasudha for this wonderful opportunity. I'd be happy to take up questions.
Yeah, thank you, Dr. Shainika, for that very nice presentation. And normally we never tend to correlate psychology, state of mind with pain. So I'll just first go back to Dr. Jayasudha, because there are a lot of questions pertaining to your presentation.
Yes,
in most Indian households, primarily what happens is we get pain in any part of the body, and we ourselves attribute it to something else, and then we go for home remedies. And as you rightly pointed out, people are perhaps not even aware of the existence of pain medicine as a separate discipline and the existence of pain clinics in hospitals. So could you please a little bit elaborate, how does a patient first identify, recognize, okay, this is the place I have to go? And what is the situation in our country? Like, where are these pain clinics available?
That's a nice question, Sumana. So basically what happens is most often women tend to ignore pain. That is one thing. And more so in housewife, they say probably it's because of the job that I'm doing, or probably if I apply some balm, it will go away. This is how, they leave it for months together. And then, it sort of becomes very vicious and it becomes very difficult to treat. So it would be nice if these patients, as Dr. Karthik said, the severity of the pain. So if somebody is having a moderate to severe pain, probably should go and seek a healthcare provider. Mostly they go to the general physicians. So what is a message that I would like to give is anybody can treat pain, because as a medicine specialty, everybody is trained to treat basic pain. But if the physicians are unable to manage, like they've given some tablets or medications for 2 to 3 weeks and it hasn't become better, they are going on coming back. So that would be a better idea at that time to, see if there are any specialized pain clinics available or specialists available to treat pain. So refer these patients early. So that will be the take home message I would like to give in this forum. It can be an orthopedician, it can be a neurologist, or it can be an alternative medicine person seeing. Try not to keep the patients to yourself. They're not going to run away anywhere. We try to do the best for our patients. And if we sort of work together, that will work well for them. So sometimes we might have missed. It will be a nerve related pain, which we are trying to treat it with some of the medications. We missed the wrong cause. We didn't find out the right cause. Or is there a psychological overlay? So, the early referral to these pain clinics will be better. I'm sure the general practitioners in the local areas will know about the existence of these clinics. So early referral would be better, ma'am. And patients also should go to these doctors as early as possible and not to keep on with the home remedy. Try for a month or so. If it's not becoming better, kindly seek the help of doctors.
So are our hospitals, say in rural areas or even the tier 2 and 3 cities, are they equipped with these pain clinics?
Ma'am, yes, in the metros, as Dr. Karthik said, there are standalone pain clinics available. And in a multi-speciality hospital, there is this dedicated pain clinics being run by doctors who are specifically trained in pain medicine. And in tier 2, like suppose take Vellore, there are about 10-15 of us practicing chronic pain, and Naruvi is one of the first hospital that has a dedicated department for pain medicine, which has been there for past 2 years now. So it's about how you create awareness. So the more you create awareness, people will come to know, and slowly your colleagues also will start referring cases to you.
Right.
It's much less in villages. Yeah, probably in a rural health sector, it's not yet percolated, but there are a lot of training programs that are happening where many specialists are now getting trained in treatment of pain. So if probably they get trained, they can also become specialists in treating pain.
Right. Dr. Karthik, like a lot of youngsters are also into gymming these days. And, they do a lot of different exercises, and sometimes they kind of a muscle gets twitched or tweaked here and they don't realize and they ignore, and we apply all local balms and, pop in some pills. So what would be your word of advice in such cases? Even when we twist our ankle many times, we kind of stay at home applying turmeric and hot oil. So these kind of small, episodes that I think frequently happen in our lives, and we tend to ignore them. So what would be your advice to such episodes, for such episodes? So you're not audible.
Sorry, if you're
Yes.
talking about a trivial injury, like a fall or a twist or a trivial injury in the ankle, so at home, what can be done for a trivial injury is, we call it RICE. So the mnemonic is RICE, RICE. So you rest the affected part, you can apply ice, you can apply compression, which could be in the form of a crepe bandage or a binder, and you can elevate that part. So if your foot is, the ankle is paining, you can put it on a pillow like that. So rest, ice, compression, elevation is something basic that we suggest for trivial injuries. If the pain is trivial, you can take basic medication at home like paracetamol. See for 2 or 3 days. If your pain is settling down, the swelling is come down, it's not red anymore, you can wait and watch. If the basic first aid and basic the mnemonic that I told, rest, icing, compression, elevation, has not helped you, then it is time to take the help of a physician. Initially, it could be a general physician or an orthopedician near you. If it doesn't work, you have to take a help of a specialist like a pain physician in a pain clinic.
Yeah, so we have already questions coming in related to that. Mr. Hargopal is saying that if the pain is not very severe, but there's the nagging pain which say continues for days, and on a pain scale of, he says 4, maybe 3 or 4, but I'm also getting used to the pain.
No, this
Then what should I do?
So this getting used to the pain is not acceptable. So what we essentially try to do is we try to find out the cause. So sometimes we look at the patient and do an assessment, and we will be able to pick up the cause immediately. Sometimes we take the help of blood tests or X-rays or MRIs and try to find out the cause. Now, you'll be surprised that a majority of these patients who tend to tolerate pain can be helped with very basic things like basic medication, lifestyle changes, braces, binders, ankle binders, wrist binders. So you'll be surprised at how easily some of these patients can be helped. So patients need not tolerate pain and carry on with life that this can't be cured. All it requires is patient needs to consult the correct specialist, and he may be doing something very simple. He may not do a complex procedure. He may not do a complex injection. He may not do a surgery. Something basic may be able to help you. One thing that commonly we mistake is sometimes nerve pain, which can be sometimes tricky to treat. Like a lot of times when the patient doesn't go to the doctor, and there are 2 types of pain. One is the bone pain, one is the nerve pain. Now, when the patient has bone pain, you take medicines, the common ones like the paracetamol and the diclofenac and stuff. And then you have nerve pain for which the medicine is different. So if you are taking bone pain medicine for nerve pain, it's not going to work. And the same way, if you're going to take nerve pain medicine for bone pain, it's not going to work. So it's a very simple thing, but your doctor needs to diagnose and guide you in the correct. That makes a lot of difference. So you need not wait and tolerate and accept these patients. Help is available. Help is available in your own city itself.
Yeah, I know that's a very valuable message because people tend to have a very high tolerance levels, and the fear of visiting a doctor is what always keeps us away from visiting a clinic. Dr. Shainika, based on your presentation, Velayuddin Menon wants to know that how often do you recommend the practice of mindfulness to patients with chronic pain?
So most of the time when patients come with chronic pain with comorbid depression, we do multidisciplinary.
Your audio is not there, Dr. Shainika.
Can you hear me, ma'am, now? Yeah. So majority of the time when patients come with chronic pain and comorbid depression, we go for both psychological and pharmacological interventions. Psychological mindfulness-based treatment is mainly based on focusing on the current moment. We ask the patient to focus on the current moment. For example, the patient is listening to music. The patient has to listen to music, focus on the current moment, be there in the moment. It's simply nothing but yoga. You be there in the moment, not focus on your pain, not focus on what is happening around, what is within the body or outside the body. You're going to just focus on the music only. So what happens if you focus only on the music? The perception and the focus on the pain will be less. So the pain perception becomes reduced. So mindfulness is simply focusing on the current moment, being there in the moment, non-judgmental. You're not going to judge the moment. So be it music, when the patient is listening to music, he or she has to put the whole attention into the music. When the patient is going to draw something, he or she is going to put the full attention in drawing. Watching TV, fully into that TV. So what will happen if the patient is being on the current moment, the pain symptom and the feelings of depression, all that will be reduced at the moment. This is why mindfulness will be helpful for both for depression and chronic pain. So be there, do more of the pleasurable activities, do whichever things you like, be there in the moment so that your pain perception is reduced.
Dr. Jayasudha, Sri Priya is asking whether there is an integrated approach for any kind of preventive care, like people go for master health checkup. So she's saying, is there a regular evaluation for such care so that even before the person reaches the stage to search for pain management?
Yeah, we are not there yet.
Yeah, I think the pain just comes.
We are not there yet. And I think that will be the future.
Right.
So we need to, so the one thing is, one thing that Sri Priya needs to understand is try to prevent acute pain. So when acute pain is happening, address it as early as possible. Don't try to, let that go. That's one thing that is there. And as Dr. Karthik rightly mentioned, there's so many small lifestyle modifications, that can be easily done. It can just be the way you're traveling, maybe the suspension in your two-wheeler, it may be the bed that you're not using properly. So correcting these small little details will almost 50 to 60% take care of your problem. You don't need any fancy things. It's just that they don't know that, you're not supposed to bend your spine like that. And somebody who's got a worn out knee will be insisting that they'll want to sit on the floor and squat. That is going to further, they'll just be so insistent. We need to tell them that this is going to make it worse. So you cannot be doing that. So these small little preventive things, I think we should start on some preventive pain clinics as well. That's a good take home for me. I'll do some work on that. Yeah.
And also, I do not know who would like to answer this question. Anupama Gopal is asking, what is the line between being aware of your pain and taking action and being a hypochondriac?
Okay, so the line is how severe it is, right? So when you want to take your pain seriously is one, it is very severe. Second is you had a fall or you had an injury following that you have pain. Second is along with pain, there is a big swelling, or you think potentially you could have broken a bone, or the place is green because there's a hematoma there, or it is red. Along with pain, you're having in fever, your pain is very bad at rest. So whenever patients are saying in the night or at rest, they are having pain, we take it very seriously. Pain associated with extremes of age. So pain in very young people, less than 15, or in very elderly people, more than 75, we take very seriously. And other than that, pain associated with something else like cough or cold or fever or weight loss. So those things you should take seriously. So whenever there is an injury or your pain is very severe, you've tried basic stuff for some time, it's not working, or you're having other features, you had a fall, you have fever, you have weight loss, you have cough, you have cold, all those things you should take seriously.
So can any kind of non-radiating pain, which is in one part of the body, can that trigger pain in some other part of the body or affect some other
Yes.
organ?
Yes. So sometimes what happens is there are two things here. One is called the radicular pain. So when you say radicular pain, a lot of times when we take a common condition like the disc bulge or disc prolapse, the patients have the injury in the lower back, but the disc comes out and it pinches the spinal cord and the nerves that go down from the back to the legs. So this can happen on one side or both sides of the body. So this group of patients will complain of back pain, pain in the gluteal region, back of the thigh, back of the knee, cough all the way to the toes. Sometimes these patients may complain only of cough muscle pain or something like that. So the same way, patients with neck problems can have radiating pain in the hand. So your doctor should assess you and find out why the pain is happening. So a lot of times the problem may not be in the place where the pain is. So if you are going to be applying your hot fomentation and warm, like a lot of times with disc herniation, we find patients are applying ointments in the cough muscle, but the problem is in the lower back. So you need to identify where the pain is coming from and treat it accordingly. So that's why visit to the doctor may be a good idea.
Dr. Jayasud, a lot of patients, as we have also discussed, tend to take painkillers. They self-administer themselves with medicines. So what would be your real strong message going out to them? I mean, because those painkillers can affect their kidneys if they're already,
Yes.
are a kidney patient.
Yeah, that's a common practice in India. They just go to the pharmaceutical, just go to the drugstore and ask them for a medication, and they give the strongest. Most often, what is given is something called a non-steroidal anti-inflammatory drug. Okay, that brings down your pain very effectively immediately. So that's the reason they go and take it. Many take in the form of injections as well. If you take knee pain, they would have taken n number of IM diclofenac, IV diclofenac. Some people even go ahead and take steroids. Again, that also decreases your pain momentarily, but leads to a lot of health issues. It can affect your kidneys, it can cause osteoporosis, it itself can cause diabetes, hypertension, and all that. So more than paracetamol, I don't think one should go and self-prescribe themselves. Paracetamol is one of the safest medications that one can take without an advice. But when it comes to NSAIDs or anything more stronger than that, I think without a doctor's prescription or a consultation, it should never be done.
Right. Dr. Shainika, a lot of people take refuge in yoga for treating depression. So does yoga therapy also help in taking care of your pain? And then it should be done under some kind of supervision?
Yoga, to some extent, yeah, for cases with mild depression, yoga is a form of mindfulness which really helps. But for patients with moderate and severe depression, because the patient has a lot of symptoms and the patient's functioning will be impaired because of those depressive symptoms. Most of the time, patients with moderate degree of depression and severe degree of depression will require antidepressants. Along with antidepressants, patients can definitely practice yoga, mindfulness, whatever may be. Patients will require antidepressants for the medications for the symptomatic improvement. because it is all changes in your brain. It's not merely psychological. A lot of circuitry changes, chemical changes, which is happening in your brain. To modulate those chemical changes, patients will definitely require antidepressants.
I think Dr. Karthik or Dr. Jayasudha maybe could take this. Mr. Suresh is saying that the interventional pain procedures are costly, and are they covered under health insurance in India or in Tamil Nadu? And are they really costly? Like, if you could just tell us a little bit.
Dr. Karthik can take this question.
Okay. So interventional pain procedures, somewhere in, let's say in my clinic or most of the hospitals that I do interventions in, may cost you somewhere around 20, 30 or 40,000 rupees. One. Second is, at this point of time, medical insurance companies do provide medical insurance for these procedures. I routinely do procedures and they are covered by medical insurance. So what we do is, before we do these procedures, we assess these patients. Once the patient's diagnosis is confirmed by MRI, we write to the hospital authorities will write to the medical insurance saying that this is the procedure, this is the diagnosis, this is confirmed by the MRI, and we need to do these procedures. They do reimburse. Sometimes your medical insurance company may ask you for 1 day admission. So usually we do these procedures and the patients stay overnight and then they get discharged the next day morning. So 1 day admission may be required, but yes, I do my procedures routinely in Chennai and I get covered by medical insurance almost always.
So there's a very specific question. It says, my Bindu Padmanabhan is saying her son has chronic pain due to livedoid vasculopathy. What should she do?
Okay. Generally, this particular vasculopathy is a pretty rare one, I'd say. One. Second is, when you do see these patients, it's mainly supportive therapy. So you should be working with the vascular surgeon. Your treatment should include what we call as vasodilators, antiplatelet medication, because it is a inflammatory vascular condition. We also may give, the vascular surgeon may also give them oral anti-inflammatory medication, including oral steroids. Now, this should be the focus of treatment rather than doing pain management in this group of patients. You can give mild opioid drugs, like the doctor should assess and give you mild opioids like tramadol, and the pregabalins and gabapentins may be useful. But the focus should be more from the vascular surgeon in terms of giving anti-inflammatory medicine, antiplatelet, and vasodilators.
Dr. Jayasudha, you had shared those statistics regarding the incidence of pain in our population, and you also mentioned that female population is perhaps affected much more. So somebody is asking that most women, they suffer from unexplained headache and they do not get relief, whether they go for treatment or they don't. So what should they be doing? I mean, does it indicate that they need any kind of psychiatric treatment as well? I mean, focusing on the women specifically.
Yeah. So women in this age group are more prone, especially post-pregnancy, are more prone to have a condition called as fibromyalgia, actually, wherein their pain perception itself, the threshold of perceiving pain itself falls down. Even for a small thing, they perceive too much. And the psychological overlay is quite high in female patients. So as we saw the biopsychosocial model, the family environment, your problems that is revolving around your family can itself cause headache. The commonest headache is actually a tension type headache. Okay, that's the commonest headache. So they everyday wake up with a headache. So if you treat the underlying cause, so if so, it is depression that needs to be addressed. So just putting them on just paracetamol will not suffice. So you need to address what is bothering them. If it is fibromyalgia, then that needs to be addressed in the form of yoga, biofeedback exercises, and then do the medical therapy as well. So it needs,
Yeah, sorry. There's another interesting question related to children. Somebody's asking that what would be a specific pain treatment in young children who tend to hide their pain and they continue to play. They don't even realize or they don't even complain. And basically children, they are saying up to age of say 8 to 12 years. So how do we handle that? How do we handle that section?
Usually, if they have pain, they do complain of pain. I haven't faced a situation where, nowadays we are seeing more patients. In fact, I've referred quite a lot of children to Dr. Shainika, 8-year-old, 9-year-old, 10-year-old. They complain of a lot of pain actually. Neck pain, shoulder pain, some sort of attention seeking also sometimes. So when these kind of children come, we first do believe in them, because as a pain physician, we are first taught to believe. We are not supposed to tell that you're imagining. Okay, so we do see them, and in children it's very difficult to assess the pain scores also. So we discuss with the parents, how do they function, what activities that they regularly do they do, or are they avoiding any particular activities. And if we don't find anything concrete, either in the history examination or even after investigation, nothing concrete, then probably I do sometimes refer these patients to Dr. Shainika. She has found quite a lot of these children to have attention seeking, hyperactivity disorders, where they sort of, do a lot of physical somatization. But the children do complain actually if they have. I haven't come across if they have pain and don't complain. I'm sorry.
Dr. Shainik, there are a lot of actually your depression related questions, but they all seem very general. Like they are saying our curriculum has changed and we are stressed, or we are in IT sector and we are stressed. So nobody's talking about pain, but they want to know about how to deal with the depression. Or it may be inducing some pain in them, which they are again not realizing. But there are a couple of questions just related to depression, related to their work and stress.
We teach simple problem solving strategies in our clinic. Okay, you have a problem. How do you solve the problem? For example, you have too much to study. How are you going to break down your portion or syllabus? Allocate specific time management. What are the possible solutions? Go for the best possible solution. And also, we often teach the link between thought, emotion, and behavior. For example, the child is saying, I'm sad because there's too much to study. The thinking goes on here is there's too much to study, which is making the child sad. The emotional state here is sad because the thinking is negative thinking here. How can we rephrase or restructure this thinking? If you think that you can you can do subject by subject, you can allocate time for each subject, you can finish that subject and then go for the other one rather than looking at a wholesome part. When they kind of restructure the thinking, saying that thinking that there's too much to study, to breaking down into parts, that kinds of alleviate their anxiety and sadness. So always we teach children and adolescents the link between thought, emotion, and behavior. Negative cognition, negative thought will lead on to a negative emotional state, leading on to a lot of physical symptoms, somatic symptoms of headache, body ache, chest tightness, or the symptoms which I had mentioned. When they restructure their cognition or change their thinking, like it is possible to study, we can break down, then their emotions also becomes lighter and they'll be able to put some effort to finish their task. So simple problem solving strategies or time management, simple restructuring of thinking will be helpful to kind of overcome the stress. Right. And can I add on one more point? Like Dr. Jayasudha was mentioning, like she was referring a lot of children with pain. So with particular children and adolescent population, children they don't have skills to express their sadness. They are less expressive with respect to their emotions, which is why they tend to somatize more. They tend to express a lot of bodily symptoms. Every day morning, child wakes up with headache. I'm having headache, I will not go to school. I'm having my stomach pain, I will not go to school. I have neck pain, I'll not go to school. Usually we see a lot of pain symptoms in children and adolescents, which is a pain somatic symptom. They somatize their pain. They tend to localize their pain to different areas of the body, which is always due to the stress, which is always, it could be multiple causes. It could be family related stress. It could be academic related stress, worries about studies or relationship issues in adolescents. Multiple stressors in children and adolescents, they tend to somatize their pain. So we do basic assessments to find out what are the stressors, And we do structured assessments, and we do find out a lot of children have comorbid anxiety, depression, conversion, somatization disorders are all very common in children and adolescent population. All of this will settle with therapy. Most of the children will not require medications. They will settle with simple 2-3 sessions of CBT or problem solving strategies. Children do settle with simple therapies.
Right. So, Dr. Jayasudha, is there a link between hormonal changes in pre or post-menopause women or premenstrual, prepubertal girls, and also postpartum depression? Is there a linkage between these conditions with fibromyalgia?
Myalgia, yes. Postpartum, yes, there's a lot of hormonal changes that leads to depression, and fibromyalgia is one such condition that happens in the postpartum period. Mostly, it's following a delivery. They go into this hormonal changes which causes depression, and the pain thresholds also decrease. So, normally a patient who was all right, you never had a symptom like that, tends to start having these kind of symptoms in 25-30 years of age, and especially if the spouse is not very supportive. So all these things do aid, do go a long way. And again, we see another peak around the 40-45 years during the perimenopausal age group. Again, due to the changes in the estrogen and the progesterone hormones, there is quite a lot of link between having these kind of pain in the muscular, diffuse pain. There's nothing specific. Pain all over the body, a very big kind of these symptoms, does have a peak like. So the 25 to 45 age group is more in favor of these kind of hormonal changes causing pain.
Dr. Karthik, Mr. Arun Kumar wants to know, like, suppose you already have a chronic pain, arthritis or induced, and then you also have a trauma, injury-induced trauma pain. So how would you differentiate? And, what is the way forward?
Okay, so if you're worried about two components here, we want to know if there is actually any tissue damage. Tissue damage meaning something is broken, something is torn, something is partially torn, like that. So in those cases is where we may ask for some imaging. So we image in terms of taking MRI scans, CT scans and stuff. And then if there is a finding in the MRI of the respective part, which could be a shoulder or a neck or a lumbar spine or a wrist, and we do find there is a pathology which is significant in the MRI, it does show that something is torn and stuff, we have to go and fix it, either by doing something like a PRP injection or a surgery or an arthroscopic surgery or an open surgery. And once this is done, if there is an underlying pain, and we may give something baseline, which may be a nerve-related medicine, which may be taken in the long term. So the differentiation is made based on imaging.
So a lot of people we see roam around wearing these lumbar belts. So how advisable it is? I mean, does it really benefit?
So it is a common myth in the Indian population for people with back pain to wear lumbosacral supports or lumbar belts. Now, the spine is not a single bone. So if you see, there are 30 bones that are stacked up one on top of each other. So these 30 bones are staying straight because the surrounding ligaments and muscles are holding them. Okay? So what happens when we wear a belt, especially in the long term, is these muscles and ligaments become weak. So if you wear a belt, the muscles and ligaments surrounding the spine will not work. If a muscle or ligament is not working, it is going to become weak. It is like saying, I'm a right-handed person. The muscles in my right hand are stronger than the muscles in my left hand because I don't use my left hand at all. So if you don't use a muscle, it will become weak. So if you are wearing the belt, especially in the long term, the surrounding muscles are going to become weak. And in the long term, the back is going to take a hit. It is not at all a good idea. So there are specific indications for lumbosacral support, like you have a broken bone, you have a spondylolisthesis, you have an infection, you have a tumor, you had surgery. So some specific indications are there. Routinely to wear the belt for back pain in the long term is not only is it useless, it is actually harmful. So probably one of the take-home points today should be people with back pain shouldn't be wearing belt in the long term. Maximum you can wear is maybe when you're taking a travel, half an hour, 45 minutes in a day. It is fine. At home or in office, routinely don't wear belts unless your spine surgeon or pain physician has recommended it. So belt in the long term is a bad idea.
Right. So a related question, Valarmati is saying that you also mentioned that we have only one spine which cannot be replaced. And nowadays, school children are burdened with their heavy weight school bags. So, and they also complain of back pain due to this overweight. So what should we tell them, or how do we help them?
Okay, so it's been a perennial problem. So what can we do is, as people who take care of spine, we have been requesting the school authorities to do something. So I'm aware of at least some schools in Chennai who have days like bag-free days, and so the book is actually kept in the school. And I know my kids go to school and they don't carry bags on, I think, 1 or 2 days of the week, they don't carry bags. Now, but again, people who are in the senior classes, 10th, 11th, and 12th, need to carry more bags. Now, there is no magic solution to it, and the doctors can only do so much in this. What probably I would suggest is, one is you want the weight to be carried evenly on both sides. So you don't want your kid to carry weight on one side. So you want a backpack which is coming nice and smooth. So you want a bit of sponge in your strap that comes around the shoulder, and you want the weight to be evenly distributed. That is one. Second is you don't want the backpack to sag too much and pull the child down. So you want it to be reasonably tight. So you want the lower end of the back to be somewhere near the gluteal or the buttock. Two, and third is, as much as possible, when they travel in the bus or when they travel in the car, you don't want them carrying it. Only once they get down from their vehicle and then go into the school class, only then they have to carry it. But again, there's no magic solution to heavy school bags.
I think we're also running out of time. Dr. Jay, so the one quick question, like Anita says that her mother has been suffering from backache, and only a recent fall identified her as osteoporosis, suffering from osteoporosis. And she seems very depressed. Now, should she go to a psychiatrist for help? Should she go to a ortho for help?
This would be an interdisciplinary management. As I said, we don't own any patients. So definitely osteoporosis is a medical condition which can also cause back pain. So if, she doesn't have any radiating pain in the leg, she doesn't have any other severe loss of sensation or muscle weakness or anything, it's just the back pain, probably she can visit an orthopedician. And if there is an overlay of depression, she can also consult the psychiatrist together or see a pain physician. So all of us are qualified enough to treat osteoporosis, because osteoporosis itself needs treatment. That itself is a separate topic altogether. So we need to check our vitamin D levels, our calcium levels, whether those needs any correction. We need to put her on some sort of a rehab program to strengthen her muscles so that they take the load and not the bones. The one thing missing in this session is probably a rehab person talking. We couldn't get, actually, probably next time when we do, we should have an exclusive session on rehabilitation. How do we strengthen the muscles? Because muscles are the main thing that takes the load off the bones. So how do we do that should be given importance. So they can very well visit an orthopedician, but also do the rehab and the psychiatry part together. So
Yeah,
that's where the
actually,
interdisciplinary approach comes.
Because there are lots of questions which are very, very specific, and people are talking about their problems, the medicines they are taking, and they're doing workouts and how long they should be doing those workouts. So as you rightly said, the rehab part, we will take up on some other edition. One quick thing is, somebody said a very simple question saying that, is there a simple blood test to find out your
Pain generator? No, that's the problem. If somebody finds that, will be a millionaire probably. Probably in future it will come up some levels of some substance P or something. The pain, it's very subjective. So
probably instead of paying money for the blood test, you should pay say, I mean, you should consult the doctor.
Right, I know that's it.
Exactly.
Yeah, but I think, yes, at least this edition should help disseminate this important message that yes, pain management is available as a different stream, and we have pain clinics with physicians who are there to take care of our problems. Thank you so much, all of you, for sparing your time on a Sunday morning and joining us for this session on, presented by Naruvi Hospitals under the Hindu Wellness series. Thank you all once again.
Thank you very much.
All, ma'am. Thank you, ma'am.